What's up, guys, and welcome to the first ever episode of Anatomy for Dummies, where the average guy talks to healthcare professionals about different injuries. My name is Noah Duva, and I'll be your host. In this week's episode, we will be talking about a tibiofemoral dislocation. And if you don't know what that is, it's okay, because honestly, neither do I. But that's why we're here. We're here to learn. On our first guest for today will be Jason Gonsalves, an exceptional anatomist who will give us a background knowledge of what makes up this foreign language known as the tibiofemoral joint. But first, let's just watch a quick little clip on what tibiofemoral dislocation actually looks like.
In your car accident, what did you hit with your knee? Was it a head-on accident or? Pardon?
Hit the back of a van.
Hit the back of a van. Got it. Okay.
Back that out. You did.
Yikes, that doesn't look like anything I'd want to have happen to me. But let's see what these professionals have to say about the tibiofemoral dislocation. All right, now that we have a visual of what the injury looks like and the severity it can have, let's welcome our first guest. Jason, welcome to the show. How are you doing today?
I know I'm doing good. How about you?
Well, I'll be doing better once someone can explain this jargon of the tibiofemoral joint to me.
Oh, my friend, you've come to the right spot. I spent the last 30 years studying the tibiofemoral joint, so you're in for a treat.
Perfect. So what can you tell me about the knee joint and the bones that make up the tibiofemoral joint?
Yeah, awesome. So for starters, basically, the tibiofemoral joint is made up by, no shocker here, the tibia and the femur. So basically, for the purposes of this, we're going to be focusing on the distal end of the femur, so the part where it joins with your knee. And there's really two structures we're intrigued with here. So the medial and lateral femoral condyles, which articulate with the tibia, and then the medial and lateral epicondyles, which are important for ligament origins. And then on the tibia's end, focusing on the proximal end. So again, at the top of your shin, where your knee bends. We have, again, medial and lateral tibial condyles, which articulate with the femur. And then in between the medial and lateral condyle is the intercondylar eminence, which is going to be important for attachments of ligaments in the menisci.
Okay, so you're talking about all these bones, but clearly the bones don't stay together by themselves. So how do these two bones stay together?
Yes, that's a great question. So basically, there's a few structures that we're interested in. So the first being the menisci and the ligaments, and as well as the muscles. But we'll look at the ligaments first. So for the knee, we have four capsular ligaments: the patellar, tibial collateral, oblique popliteal, and arcuate popliteal ligaments. More specifically for the tibiofemoral joint, we're going to focus on the LCL, which is the lateral collateral ligament, and you can find it on the outside of your leg. And then the MCL, the medial collateral ligament, which you'll find on the inside of your leg. The intra-articular structures within the knee joint are the cruciate ligaments and menisci. So inside here, we're looking at the ACL, so the anterior cruciate ligament, and the PCL, the posterior cruciate ligament. And then, as I mentioned before, the menisci. So we have two menisci, the lateral and the medial. These are concentric plates of fibrocartilage on the articular surface of the tibia that deepen the surface of the joint and act as shock absorbers. They're wedge-shaped, which they're thicker at the external margins and tapered to thin in the middle. They attach to the intercondylar area of the tibia. This is very important as it increases form closure. Otherwise, you just have your tibia and your fibia sitting there with no menisci, just flopping all over the place. And nobody wants that. And then also, which is very important for this joint, that primarily holds it together, are the muscles and tendons. So most important here would be the quadriceps and also the hamstrings helping out in the back. And then also the tendons of these muscles holding it together as they attach to the bone.
So Jason, how does all of this impact the tibiofemoral joint and tibiofemoral dislocation?
Yeah, so we can see after reviewing the anatomy here, we're starting to get a complete picture of the joint. The menisci add to deepen the joint, which significantly increases stability, and along with the contribution from the ligaments and muscles that also support the joint. In regard to tibiofemoral dislocation, we can see how the anatomy of this joint dictates that it's quite stable and makes a full tibiofemoral dislocation uncommon.
Wow, that's a lot to take in. You brought some great knowledge to the listeners of this podcast. Thank you for coming on the show today.
Awesome. Thanks for having me, Noah. Anytime. Take care.
All right, so let's welcome to the show our next guest, ER doctor, Brandy. Let's get started with something easy here. What exactly is a tibiofemoral dislocation?
So dislocations are classified as tibial displacement relative to the femur, and there are several different types of dislocation. So there's anterior dislocation, which is excessive hyperextension, often at a high velocity. Posterior dislocation, which is often performed in an excessive force to the tibia while the knee is in flexion. There's also lateral or medial dislocation, in which excessive force is rotational or valgus or varus.
Yikes. So that sounds pretty painful. In your experience, what usually leads to this type of injury?
Okay, so let's start talking about mechanisms of injury. Dislocation is usually caused by significant forces delivered in a violent manner to the knee. There are two classes of dislocation. High velocity, which is caused at a sudden and extreme force, such as a car accident, resulting in vast damage to the structure of the knee complex, including disruption of menisci and cartilage, and are more likely to result in neurovascular damage. There's also low velocity, which generally occurs in a sports setting and is associated with lower rates of neurovascular and soft tissue damage, and is a much better prognosis than high velocity.
So with that said, what happens when someone dislocates this joint?
So commonly both the cruciate ligaments are torn, with only one of the collateral ligaments tearing. There are cases where only one of the cruciate ligaments are torn, or sometimes both collateral ligaments. Possible tearing of the popliteal artery, which can cause internal bleeding and loss of the lower leg. And then there's also possible tearing of the tibial peroneal nerve, causing loss of function in the lower leg.
Yikes, all that sounds quite painful. Well, thank you for bringing some light onto this, and thank you for coming on the show today.
Well, thanks for having me.
All right, I'd like to welcome our next guest to the show, physiotherapist William. William, how's it going?
It's going good. How are you doing today, Noah?
I'm good, thank you. So on today's show, we've just been talking about tibiofemoral dislocation, kind of explaining what it is. And we're just having you on here to explain, how do you go about treatment of a tibiofemoral dislocation?
Okay, perfect. So first off, we can start consider treatment as soon as the person is able to begin it. So that things like using upper body and mid body exercises to start, and then allowing for single leg stationary bicycling. So we would just have them using one leg at a time to build up that strength and maintain cardiovascular conditioning, as well as emphasizing quadricep strength so they can start rebuilding the strength in their leg. And then as we start progressing into weeks, like over a month in, we start having them do both leg sizes and using exercises like biking, swimming, so it decreases the load bearing but still gets that cardiovascular and increased muscle increased muscle mass starting to happen again. And then we also do this to make sure our patella is not going to be pulling to one side, because we want proper patella tracking when rehabilitating to prevent patellofemoral problems. And then when we're starting to do these problems, we have them in a leg brace to allow 40% extension and 70% extension, so that we're not increasing damage to the joint. And then after 7 to 8 weeks, we unlock the brace so they have full range of motion. And then we start doing things that have weight bearing, and like with crutches or just weight bearing, depending on how they come in about.
Wow, sounds like quite the process. Thank you for coming on and shining some light to that for us dummies that don't understand anatomy.
Perfect. No problem. Anytime.
Well, it was great having all of these guests on and giving us a great insight into the tibiofemoral joint and what a tibiofemoral dislocation really is. It is clear that the anatomy influences the condition, and the condition influences the anatomy. We can see this as structures holding this joint together keep it quite stable while allowing for good mobility. It is because of these structures, such as the ligaments, menisci, and muscles that hold this joint together, that tibiofemoral dislocation is quite rare, only really seen with severe force, such as a car accident. However, on the other hand, we can see that when the tibiofemoral dislocation occurs, damages the intricate structures that keep the joint together. Thanks for tuning in to Anatomy for Dummies.